So basically, there are three mechanisms involved in the chronic itch. And the first one is increase in number of chemical mediators that can directly elicit the itch nerve endings. This is a cross-sectional view of our skin. We have three skin layers. The itch nerve fibers firstly can be stimulated by the mast cells, not just the histamine, but also the non-histamine like tryptase on the PAR2 receptor. And the Th cells produce IL-4, 13, 31. And bear in mind, keratinocyte does not play a passive role. In fact, they're actively involved in itch and inflammations. Upon stimulations, they start to produce different cytokines, include the TSLP, IL-33, that again can directly depolarize the itch nerve ending. They're further stimulated by the fibroblasts via the prolastin, especially in prurigo nodularis. Upon stimulation, the itch nerve fiber will travel along the unmyelinated C fiber, the slower one, or the myelinated A delta fibers along the spinal thalamic tract to the cerebral cortex and initiate the itch scratch cycle and the inflammation, and the process will perpetuate.
And cytokines such as interleukin 4, interleukin 5, and interleukin 13, play such a big role in atopic dermatitis, and that's where we really want to hit patients with our biologics. And we now know that Th2 inflammation is not only inflammation on its own, but interacts a lot with the other factors that are involved in the pathogenesis of atopic dermatitis, such as the skin barrier, the microbiome, as well as the sensory nervous system that causes all the itch. So, just by reducing the Th2 inflammation, you improve the skin barrier, you improve the microbiome, you actually also reduce the sensitivity to all the itch and nerve endings. So going on to the JAK STAT signaling, so what happens after IL-4 and IL-13 is triggered is that it then interacts with the JAK receptors. So there's the different kinds of JAK receptors, and in atopic dermatitis, it's been shown that JAK1 plays a very large role. So you need to try and block JAK1 if you want to try to reduce the the clinical features of atopic dermatitis. So after IL-4 and IL-13 activate these JAKs, they actually dimerize and then move into the nucleus, and this then causes genes to be upregulated that leads to keratinocyte differentiation, Th2 cell differentiation, class switching, as well as the pruritus that you see in atopic dermatitis.
The mechanism of action of JAK inhibitors, but just to mention over here that it is actually blocking the interferon gamma related pathways and the related cytokines in vitiligo, thereby stopping or blocking the melanocyte apoptosis and the further damage leading to the depigmentation. With regards to narrowband UVB, what it is essentially doing is more of melanocyte stimulation. To a certain extent, it is doing a local immunomodulation as well. But majority of the work that it is doing is of a reduction of the reactive oxygen species, melanocyte stimulation, and local immunomodulation. With regards to oral corticosteroids, it is doing a gamut of functions. So it's working on the lymphocytes and reducing, it's reducing the lymphocytes and their functions, the Langerhans cell-related functions. It is decreasing the synthesis and secretion of IL-1, IL-2, again, interferon gamma and TNF. So that's how it is reducing all your pro-inflammatory cytokines. It is also reducing the complement-mediated toxicity. It is increasing the dendriticity and the. So for us, I think in India, the challenge that we face is there is a lot of stigma associated with this disorder. And I think that's the same with Bangladesh and Sri Lanka as well. And the parents are in panic mode when the disease in a spreading state. So, you have to pull all strings to bring this down as much as possible without really causing any harm to the child. So for now, I think the safest bet, if the patients are affordable, is to go ahead with tofacitinib. But if not, then oral corticosteroid. I prefer the low dose because I think it is easier to taper. That's what I feel. But again, physician preference comes into play. So a lot of doctors are also using oral minipals for pediatric age group as well.
But I think that's something that you brought up also. I think it's always a dilemma in the clinic as well when, I have a 3 or 4 year old that gets brought in for vitiligo, darker skin. And it's in an area that is, pretty hidden away, like, the tummy or the leg or the butt. And the parents are the ones who are insisting on treatment, wanting oral treatments and all that. And then, for the child is really not affected by it, especially if it's a hidden area. So in these kind of cases, I mean, how aggressive will you be, when it's the parents that sort of insist on treatment or aggressive treatment?